Good morning. Thank you for joining us today. My name is Dr. Jennie Ward-Robinson. I am the CEO of the Society to Improve Diagnosis in Medicine, or SIDM as we are more popularly known, and I'm pleased to serve as the moderator of our Future of Diagnosis webinar series. For those of you that are new to SIDM, we are the only organization focused solely on reducing patient harm as a result of diagnostic error due to missed, delayed, or misdiagnosis. And when I say the only organization, I speak through a nonprofit lens. Since becoming a tax-exempt organization, SIDM, with the help of committed partners and patients, have contributed to advancing this field of diagnostic error, of which patient safety and quality improvement are key solutions in reducing patient harm. I invite you to visit our website where you will learn of our work and where you will find resources to assist you in your diagnostic journey. As a patient, you will find webinars, podcasts, and active tools that offer roadmaps in your journey. As a clinician, you will learn of our various programs, such as the Small Grants Program, where we work towards solutions, our fellowship in diagnostic excellence, and of course, how you may join and engage with us in support of our efforts. Today, we are discussing how doctors and patients can work together to improve patient safety. And we hope to offer insights for both patients and clinicians to limit diagnostic error. Our esteemed panelists, Aubrey McKernan, Colonel Stephen Coffey, both represent the patient community. They will be followed by Drs. Harry Hoare and Ronald Wyatt, who represent the clinical community. Our panelists today will offer a brief summary that will address one from the patient's advocate's perspective. What do you wish your doctors knew to avoid a missed, delayed, or incorrect diagnosis? And I'll ask the doctors equally, what do they wish patients would tell them to help them develop and deliver an accurate and timely diagnosis? Now I will introduce each panelist, invite them to take 5 minutes each to share their comments. And after they're spoken, I will open up the discussion to include questions from the audience. So let me start with a few housekeeping rules. Attendees, your cameras are off and microphones are muted throughout this session. Please submit your questions for the panelists using the Q&A feature. The chat is closed. This session is being recorded and it will be posted on the Improved Diagnosis website. So welcome. Let's begin by meeting our panelists. First, we will hear from Aubrey McKernan. Ms. Colleen McKernan is a research and programs manager for SIDM, and she joins SIDM with not only 10 years experience managing clinical and behavioral health studies, but she joins us with a personal story that she will share with you today. Next, we will hear from Colonel Stephen Coffey. Colonel Coffey is the Director of Military Personnel at the National Security Agency. He is a recognized expert on how to meaningfully engage patients and families to improve patient safety. Colonel Coffey is the co-founder of the WHO Patients for Patient Safety US, and it is through his son, who is a sepsis survivor, that he is inspired to be with us today. After our patient panelists, you will hear from Dr. Harry Hoare, our first physician panelist, who is a doctor of internal medicine and a pediatric hospitalist and medical director of quality assurance and director of clinical reasoning education at Bay State Medical Center, UMass Chan Medical School. He created the Clinical Reasoning Academy, a novel interprofessional education series that bring together providers, nurses, and other medical professionals, patient advocates, and patients in order to improve quality and safety culture at Bay State. He is a longtime member of the Society to Improve Diagnosis in Medicine, and we are fortunate and excited that he is the co-chair of our upcoming SIDM 23 conference to be held in Cleveland this year, October 8th to the 10th, where the focus will be the future of diagnosis, achieving excellence and equity. And finally, we will hear from our very own board member, Dr. Ronald Wyatt. Dr. Wyatt brings more than 30 years of experience in healthcare, serving in many roles, including his role as a member of the board of directors of SIDM. Most recently, he was the vice president and patient safety officer at MCIC Vermont and chief quality patient officer at one of the largest public health systems in the US. Dr. Wyatt is nationally and internationally recognized as an expert in patient safety and was named several times by Becker's as one of the top 50 patient safety experts in the US. Dr. Wyatt was the first patient safety officer at the Joint Commission, and in that role contributed to national patient safety goals, Sentinel events, and he developed the Quick Safety publication. He is internationally recognized for his leadership in patient safety, to include safety analysis, human factors in healthcare, patient experience, and patient equity. He serves on many boards, including the IHI Certified Professional in Patient Safety and the Society to Prevent Diagnostic Error. He is a credentialed course instructor in the School of Public Health Professions at the University of Alabama, Birmingham, and he is a graduate of the Alabama Birmingham School of Medicine. He also holds a master's degree in executive health administration from the University of Alabama at Birmingham. I think you're going to be very excited at our panel. And with that, may I invite Ms. Colleen McKernan to take the stage, who will be followed then by Colonel Coffey. Thank you. Welcome, Audrey.
Thank you so much, Dr. Ward-Robinson, for that introduction. Good morning, everybody. My name is Aubrey Colleen McKernan. Thank you for the opportunity today to share a story from a patient advocate standpoint. I lost my father ultimately to misdiagnosis in spring of 2018. He was 54 years old at the time, very healthy and active. He woke up one morning with severe left pain in his leg and arm, and the left side of his face completely swollen, and felt very lethargic. Out of precaution, I convinced him to go to the emergency room early in the morning. He explained his symptoms to the emergency medicine team, and from their evaluation, their conclusion was that he was having an allergic reaction to something. So they decided to give him some IVs, monitor him for I think about 2 to 3 hours, and sent him home with an EpiPen. His swelling did go down significantly when he was there. So he was sent home and spent the rest of that afternoon resting and trying to kind of start to feel better. And not even 24 hours later, early in the morning, my father suffered a massive pulmonary embolism that broke off from his left leg and traveled to his lungs. In a panic and trying to assess the situation, I called 911. I initially thought he was suffering from a heart attack or something similar. Came in and out of consciousness a few times. And by the time that ambulance arrived, they loaded him up and quickly rushed him to the hospital. They were able to revive him one time in the ambulance on the way to the hospital, but ultimately was pronounced dead about 10 minutes after arriving at the hospital. This all happened within about an hour early in the morning. And I was 25 at the time, so a very young girl, and who just went through something very traumatic, and not only losing my father, but not understanding why, and not being able to pinpoint a specific diagnosis of what caused him to pass away so quickly. And after we got the report back summarizing, turned out that my father had the genetic mutation of factor V Leiden, which makes him more susceptible to blood clots. And it actually is a very common hereditary gene. And I, out of precaution, got tested myself after him passing and found out that I also have that gene. So after going through something really traumatic and really hard, deciding to try to turn that passion into something that was meaningful and living on his mission, and really happy that I took the steps to get tested and understand exactly what caused him to pass away. And not only for myself to be able to understand that I am susceptible to blood clots, and there's different precautions that I can take moving forward now that I know that. But I think that's also something I wish that could have been evaluated or maybe assessed during his first initial trip to the emergency room. So you can't change the past, and I think we all know that, but we can strive to impact the future. And for my dad's story, I hope I'm able to continue to spread awareness.
Thank you, Aubrey. We are happy that you're with us in this fight, and I know that propels you. Colonel Coffey.
Thank you so much, and good morning. So if I could start by quoting one of my favorite authors, Charles Dickens, when he said that it was the best of times, it was the worst of times. It was the age of wisdom, it was the age of foolishness. Those words never rang more true than with the birth of my son, Stephen Coffey II. In his life, my life would change forever as a new father, but the world would also be introduced to this living miracle. So Stephen experienced a diagnostic error. It was a misdiagnosis and a delay in diagnosis of his metabolic condition, galactosemia. I was a young airman, an officer, but still a young airman in the Air Force, in the military health system. And Stephen had a metabolic condition that is not something that is seen often in military medicine, whereby his body, through his condition of galactosemia, could not break down the simple sugar, galactose, that's found in human and animal milk. And so we were in the hospital, he was born, I was excited, I was gonna have a son to carry on my good name. And the nurses took him away and said he has this high bilirubin, this low glucose, and that he was a little bit jaundiced, but lethargic, but he would be okay. They assured me he would be okay. What I later found out is that his condition of galactosemia caused him to really get sick. It really caused him to get sick drinking his own mother's milk. We were rushed to the hospital. Pardon me. We had a phone call from his provider, and it was an interesting phone call because it was something that we took on speakerphone. As new parents, we want to both hear what the doctor says. And the doctor says he has this condition called galactosemia and told us to run to a larger hospital so that we could get more testing done. And so I'll pause there just for a moment to say there's so many threads in this tapestry that make up his experience that we can pull from, and hopefully we'll get to in some of the questions. But as I went to this larger hospital, I couldn't spell galactosemia, I didn't understand it, but I was forced as a patient to explain it to providers. What we later found out is that his metabolic condition caused him to go into fulminant liver failure. And so on November the 28th, 2012, I got told for the first time, 2 months into his life, that Stephen has galactosemia and he has fulminant liver failure and would require a liver transplant. And a week later, he was transplanted at 8 weeks old with a 7-year-old transplant donor. So it causes me to be in this space. The pain that he had went through fueled the passion that I have now to put me in this space. But it also causes me to think of these what if questions, these what ifs. What if there was a more conservative approach in his care? If the provider who had told us that he has galactosemia told the hospital, the larger hospital, that we need to really do more testing immediately and called ahead. There's a communication barrier that we experience because of the phone call we received on speakerphone, the communication barrier of, as a layperson, trying to communicate a very complex medical diagnosis to medical providers. What if there was communication consensus among the providers? When we were discharged from the hospital, we ended up having the larger hospital say, don't worry about this condition. We don't want to adjust his take for milk, his normal milk. You're still okay. He only has a trait for galactosemia, when the smaller hospital said, no, he actually has this condition. 2 conflicting phone calls and 2 different, in a sense, discharge orders on the same day. What if there was collaboration amongst the hospital, the phone call ahead? there's so many things that we could pull apart in those what ifs, if you will, that kind of weave into this tapestry that made up his life experience and our story. And I hope again that we'll be able to get into some of those things through the question and answers. I really appreciate this opportunity to start the conversation of how we can better partner with providers to improve diagnostic care. Thanks.
Thank you, Colonel Coffey, and we continue to learn from you and your son's experience. And now I'll invite Dr. Hoare to the stage.
Thank you, and it's a pleasure to be here. So I was asked to talk about, what do we as providers wish that patients would share with us to help us with the diagnosis and help us really partner with patients to make a diagnosis. And I'll start with, there's a very sort of common, almost cliche words of wisdom that we provide medical students from the start. 90% of diagnoses can be made on the basis of history alone. And that may or may not be an accurate number, but the truth is that having an accurate history is really the starting point for the diagnostic process. And what's important around the history is really the chronology of it. When did these symptoms start and how have they progressed since then? That sort of thing. So it really is helpful to know if you are planning to see a doctor for what's going on with me, what's going on with my child, what's going on with my parent. Having that timeline as best as you can is really, really helpful. When did this start and how has it changed over time? Who have you seen in the past and what did they tell you? And knowing your past medical history as much as possible, your family history as much as possible, and kind of what's going on in your life. There's what we call social history, but I think is just, your life and the people around you and the things that you do in your life. And another thing I would say, if you carry a diagnosis of a chronic condition, let's say rheumatoid arthritis, for example, it's really helpful in many cases for us to know who made that diagnosis and when, and what kind of information did they use, what kind of testing did they use to make that diagnosis? Because we certainly know that some diagnoses are hard to make. And sometimes if something gets into someone's chart, it can persist and become, it can build what's called diagnostic momentum. So if someone's once said, this patient may have lupus, the next person may see that and say, oh, this is a patient with lupus. And pretty soon we're carrying this diagnosis of lupus that we may or may not have. And so it's important to know what are the diagnoses I have and how did we get there? Because history is so important, we providers will often ask you questions that either seem somewhat invasive or really embarrassing. And we ask, it's really important that we try to answer those questions as honestly as possible. I remember a patient who was a late mid-teen, really good hockey player. He presented to our children's hospital unable to walk. And we did a lot of testing. It included spinal taps and MRIs and lots of lab work and neurology counseling, all these things. And we came to the conclusion that this looked like what is called a functional neurologic disorder, which is kind of a stress response. We asked many different ways, is there any stressors that are going on in your life? And it wasn't until actually one of my colleagues who happened to live in the same neighborhood as this family, the family's like, no stressors, no. He came in and he said, hey, did you know that his father was arrested like 2 days before these symptoms started and he's in jail now? That kind of thing would have been really helpful for us to know in that process. So we're not prying when we ask questions. We almost always. I can speak for myself. We're looking for information that's important to the diagnosis. The other thing is, whenever possible, bring someone with you who knows you and knows your story well and is going to advocate for you. We've all had that experience where it's sort of easier to speak up on someone else's behalf than it is to speak up on our own behalf often enough. And so I think that's really valuable. I had a patient not too long ago in the hospital who was here because of an injury, of an accident. The family was really concerned about some cognitive impairment that this gentleman seemed to be developing. He was really concerned too, but he wasn't willing to bring it up. And his family, his daughter said, we're going to talk about this. And we were able to start the process of getting to a diagnosis, even though he came in for a completely different reason. That was unrelated. So as much as it's important to bring someone with you in many cases, also if you are the patient or you are that support person, also know that it is important for the physician and patient to have some one-on-one time together as well, and to excuse yourself from the room, or hopefully the provider will prompt you to do so. An example I see all the time in the children's hospital is we have a teenager, the parent is there, and we say, well, I'm gonna ask you to leave so I can ask some other questions. And a parent will often say, oh, we share everything. There are no secrets here. You can ask this question. And many times my learners, my residents or medical students say, okay, and they ask the questions. When I come in, I say, well, still, this is a routine part of what we do, and excuse the parent. And sure enough, many times there is something that is shared in the absence of the parent that would not have been shared otherwise. And then one of the other things I want to say is what I see in the hospital setting is there are many times when people get frustrated that another doctor is coming in the room and asking them pretty much the same questions. Hey, tell me your story. And I want you to think about, try to have as much patience as possible with us. There's lots of reasons why that happens. And many times people are like, do you guys not talk to each other? Are you not communicating? Why am I telling this story again? But each of us approaches this from a very different perspective. An emergency room doctor is really trying to figure out, is this something life-threatening? And what's next for this patient? Is this patient going to be able to go home safely, or are they going to need to come into the hospital for a time period? And then if they come into the hospital, then the next person is really more focused on, okay, what exactly is our diagnosis and treatment plan here? So they may ask questions from a different perspective and may do different things with that information. There's also varying levels of experience amongst providers. So please bear with us when we ask you to repeat yourself. And the last thing I'd like to say for sure is, if you feel like a healthcare provider or organization just didn't get it right in your case, as long as you feel like they treated you appropriately and you can work with them to some extent, please come back to the provider and or the clinic and or the health system that you first went to, because having that prior information and knowing, hey, this didn't work out like we thought, is really valuable. The tendency is to say, well, they didn't get it right there. I'm going to go to this other hospital. This happened to me just last night. I was taking care of a patient. Well, there was a patient, a child who was 2 years old, who presented to our emergency department with a seizure and was discharged from the emergency department, and which was routine standard care for this particular type of presentation. Had another seizure, went to a hospital that's about a mile away from us, that does not have a children's hospital. So at that point, the situation had changed, and that patient did need to be admitted to the hospital and be observed and evaluated more. So this required that the other hospital call us, the patient be transferred over to us, and then brought upstairs. And I just want to encourage people that if a place knows you well and you feel like they care about you, please continue to go back. Because having all that information in one place is really helpful. That's where I'll stop.
Thank you, Dr. Hoare. You've given us lots of things to think about, and questions are being presented about what you've said, which I hope will bring a lively conversation. Now I'll invite our final panelist, Dr. Wyatt, to take the stage.
Thank you, Dr. Robinson, and thank you to Aubrey and Colonel Coffey and Dr. Hoare. What I'll say has a lot to do with what's already been said. And I will say that it is, in my mind, unfortunate that we have to talk about the future of diagnosis. So for me, what is old is new again. And just a bit more background. When I left active practice, I had over 6,000 active patients. That's a lot of people sitting in a room with for over 20 years. And most of what I know about caring for people came from people that sat in front of me, not from the medical textbooks. That's subject matter knowledge. That is not enough. So I'll go back to two people that I still rely on when I finish training, who gave me advice to live by. H. Philip Venable in St. Louis, practiced there for years. What he said to me as I was leaving training was that when you go into practice, you're going to think you know everything. And you're going to be eager to tell everybody that you meet how much you know and how well you're trained. Then he said this: don't do that. Sit down and shut up. People that come to you over 80% of the time will tell you exactly what's wrong with them. You sit and listen. When they finish, now you can repeat it back to them in medical terms, and then sit with them and partner to create a management plan. But people have already told you, and I'll rephrase it, people tell you what matters most to them, what matters most to their family. We need to sit and listen. I was fortunate for 3 years to spend time with Joe Sapira, who wrote a book and was writing a book when I was in training called The Art and Science of Bedside Diagnosis. Joe said the same thing that Dr. Venable said: sit and listen to people, and then begin to piece it together based on what they're saying to you, and go back and go back. Because when you go back, what you're doing is building trust. And I'm going to come back to trust. But as you heard Aubrey talk, and as you heard Colonel Coffey talk, and as you heard Dr. Ward tell the stories about people, people come to us with what matters to them. They bring their trauma. They bring their historical trauma. They bring their political, their social, and their economic lives through the door with them and sit in front of us. And we need to understand to pull your head up from that iPad and look at people and listen and embrace what people are saying to us in order to make the correct diagnosis, the timely diagnosis, and be able to communicate that back. Colonel Coffey, at the Joint Commission, one of the top root causes of failure is failures in communication. And to your point, failures in care coordination. So what I'm saying is there's a set of competencies that are lacking in the diagnostic process. So we need to think about that. The other thing that all too often is missing is humility. So this is a humble profession. And humble profession requires humble listening. It requires humble inquiry. And what we know, and the empirical data supports this, there has been what we call a trust decay. And sadly, you heard that from Aubrey and you heard it from Colonel Coffey. What has happened, these experiences that I've heard so many times, causes a trust decay. We need to restore that trust. Mistrust, distrust, no trust. That starts where? And Harry, you talked about it. Starts with empathy. It starts with caring more about the people that come to us than we care about ourselves. The next, can we apply our logic and judgment to every person that comes to us and their families, using that logic for all people, not just some people, not based on your skin color, your insurance status, your education level, but for all people. The next then, when you come into a clinical setting, is to demonstrate that you are genuine and that you are authentic. And you begin to build that trust. And when we fall short, apologize. Say, I'm sorry. And I will stop there.
Thank you. I'm busy noting the questions that are coming in as you are speaking, because your comments and feedback is so timely and clearly based on the questions. There's a receptivity and a readiness for it. So I want to begin with a couple of questions. And, you know, when we convene webinars, we always tee up questions just in case, but I have to tell you, I don't have to tee up questions because of some that have been received. So one question, and this goes to Dr. Hoare, you mentioned diagnostic momentum. And that is something behind the curtain, the author says. So what can a patient do about that when the patient does not have access to this construct of diagnostic momentum?
Excuse me, great question. So one thing that comes to mind immediately is that now, you know, patient portal is and should be available to nearly all patients. And I'm sure there are some limitations there in some places. And depending on the age of the patient, I know in pediatrics, there's a little challenge there, but for one, diagnostic momentum really, it happens in the chart. It happens as something gets typed in, input into your history again and again and again over time. It really, you know, the next person is not going to say, how and when was this diagnosis made? They're going to see 15 different people and 15 different documents have put this diagnosis in here, so it must be real. I don't have a lot of time to explore every single diagnosis a patient has. So if you are able to get into the patient portal, you're able to open notes, that sort of thing, and review your records, then you can find, and this happens not infrequently for folks who are able to get in there, and look and say, you know, no, this is wrong. I don't have this diagnosis. The other thing that you can do short of that is, you know, many times in the encounter, and at least in the hospital setting, we're getting to know someone for the first time, and we may have a lot of records about them. And if we sort of come in and if we do things like we do on pediatrics, which is called family-centered rounding, where our team and the nurse and the patient and the parents, caregivers are there in the room at the same time, we're reviewing their history together, speaking in a language that is understandable, ideally. That's hard to train our doctors to do and our medical students to do, but that is the goal. There's many, many times where a parent will say, wait a second, no, that's not accurate. And it's, you know, we try to really even open that conversation by saying, we're going to review your history so the team is on board. If you hear anything that we get wrong, please interrupt us and let us know. So I think in some cases that you're not going to be given that introduction, and we'll need to really jump in and say, and that's the importance of knowing your history and knowing how was the diagnosis made and when by whom. Yeah, I'll stop there.
Yeah.
Thank you, Dr. Hoare. And I'm sorry, Dr. Wyatt.
Yeah. So I'm a patient and I go in for my annual physical and I have access to the patient portal. And after a visit, I'm looking for my lab results, my diagnostics, and I wait and I wait and I wait. And I can't access my results. Then I get a message through the portal from the nurse saying, the doctor wants you to start on a statin drug to lower your cholesterol. And I don't have the lab results in the portal. Right. Now I'm a person who's got quote unquote good insurance and MD behind my name. I'm just gonna provocatively say it doesn't matter. Because I tried to communicate back to that academic medical center and could not. My message back to them was, I will not start a statin until I talk to you. I got no response. When I went in for my visit in December, I asked, why do you want me on a statin? Because based on the calculator, and I have the ability to do this, there's a question about whether I should be on a statin, because that statin that's going to cost me will add about 18 weeks to my life, if that. And if I choose between a statin that's going to make me live longer and a Coca-Cola and a moon pie, if I only got 8 weeks left, I'm going to take the Coke and the moon pie, not a statin. So I said, explain this to me. And I said, and you know, I need some baseline liver function tests so that I'll know where I start if you put me on a drug that's going to go through my liver. His response, a board certified internist response to me was, oh, well, we can do those tests because you have good insurance. All right. So that's the real world we're talking about. And I'm an empowered, activated physician. Think about the average person that goes in and is afraid of that person. And I had to say to this young internist, put your iPad down and look at me. You can check your boxes later. You're trying to impose a chemical on me without giving me logic. That's what I mean by logic. If you can't look at me and you spend more time on your iPad, you're not authentic and you're not giving me the respect that any person deserves. You're concerned more about yourself and checking the boxes and getting through that visit than you are about me. That is a lack of empathy. I will not trust you and I will not go back. And I will say that on my HCAP survey. And it's unfortunate, and I'm speaking now to if there are healthcare administrators on this call, don't put clinicians in that situation in the first place. That they are measured more by RVUs and checking the box than they are about engaging with and building relationships with people, building trust and coming to the right diagnosis and creating a management plan that's going to help that person and that family. I'll stop.
So, Colonel Coffey, go ahead.
I just want to jump right before you move to the next question. I know they're flooding into the box, but there's
No
a very
worries.
important thing, I think, from that patient perspective that is also really important. And both Dr. Wyatt and Hor touched on this. So yes, we have access to the medical records. Yes, we need to build trust, but in building trust, there comes a change in the mindset as well. So when you think about the parent-child relationship, it's very similar to what sometimes a provider-patient relationship is. And it shouldn't be that way. So in a parent-child relationship, I tell my 10-year-old son, go do this. Don't ask me questions why, just go do it because I know better. And he'll go do it. In that provider-patient relationship, sometimes it's that same kind of mindset as a parent or as a caregiver of a parent, of a patient rather, that provider comes in and says, take that statin. Don't ask me questions why. Take that statin because I said so. And so there's a change of a mindset and that paradigm shift that we have to get to that will help us to improve diagnosis in medicine. Think back to the Hippocratic Oath. I'll swear to fulfill to the best of my ability and my judgment, this covenant that I will respect the hand that I, all the way through that Hippocratic Oath. It is my judgment. It is my experience. It is I. There's nowhere in there where it involves the patient as a partner in care. The last thing I would give you is, it's kind of a tagline I always say. I worked in the Pentagon for many years, and I would go to the Pentagon and I would see the Starbucks and the Dunkin' Donuts on the same floor, right beside each other, competing for your business. I take people on tours and they're amazed, but I never really notice or recognize the things that are on the wall because I see it every day. And I translate that into the hospital experience, because what I find is that when I go to the hospital with my son, we are 10 years post liver transplant, and he had a challenge over the Christmas holidays. We were in the hospital inpatient for about 9 days, and I still recall that it is a significant emotional event. 10 years post-transplant, it is still a significant emotional event. When providers go into a hospital, they don't see how sterile the walls are. They don't see how poor the signage is. They don't see that when they're talking in medical terms, that it is really a foreign language to the patients. It is a significant emotional event when we go to a hospital, because I'm only going there if I'm sick or someone I know is sick. In the same manner that when I go to the Pentagon, it matters not to me what is on the wall. So I think that it's important that we start to look at how do we change and shift that paradigm of engagement with patients and remove that parent-child relationship and look more to strive to make a partnered relationship. Thanks so much.
Would one of you want to respond to that? It actually aligns very nicely with a question that suggests there's been lots of review, lots of study, lots of analysis. How do we get the rubber to meet the road, quote unquote, i.e., get physicians to modify their approach to patients and the diagnostic process? Would one of you want to take that question? Dr. Hor?
I was hoping Dr. Wyatt was going to step up, because that's a hard one.
I'll give you a
Well,
minute
we
to
really
think
have
about it,
been-
because as a patient, I've got plenty of. I'll give one quick comment, and that's why I'm interested in your thoughts on this as well. I think that for us to really start to get that rubber to meet the road, one, it takes educating the young and regulating the old. Kind of a catchphrase, but it's true. We educate the young because it's a cultural mind shift in medicine. And how do we get there? It's some of the stuff that Dr. Wyatt talked about. Don't box me in as a provider to do these many patients in these many hours, because that affects care. It is telling those young residents, those medical students, how do we actually look at patient safety? How do we look at how we care for and partner with patients in the educational part? Because oftentimes when you look at medical school, and my sister, she's a medical doctor as well, there was not a time that she was taught, how do I partner and care for patients? She understood the diagnosis. She understood about the treatment options, but she never learned how to really partner with a patient and understand that perspective. So I think it is educate the young, regulate the old, because you got to have a carrot and a stick oftentimes to get folks to change ways. But it really is about setting a new tone and tenor and a cultural change in the practice of medicine.
So I was typing in some answers. Can you restate the question for me, Dr. Robinson?
The question has to do with, let's see here. It has to do with communication and actually changing, having physicians. The caller said, have the rubber meet the road and create a mind shift between the idea of the physician and the patient interaction in order to improve the diagnosis. And I want to build on that and actually reflect back on what Aubrey presented. So here's a young lady presenting, seeing her dad's symptoms, calling the ambulance and going through that 24-hour that resulted in his death. As a physician, what could you have elicited from her, or what environment could have been created to allow Aubrey to perhaps describe more information that could have influenced the first contact when he presented at the emergency room?
Yeah. So I think that goes back to the title of this session, the future of diagnostic medicine. What I know from experience, from teaching, from mistakes I've made, from the work I've done over the years, it starts with how we begin to identify and eliminate our own biases. All too often in the ED setting, other settings, we are anchored in bias. And that bias can be related to several things. Person's too old. The person doesn't have the right skin color. The person is not dressed the way I think they should be dressed. The person doesn't speak the language that I speak. All of those things start to play out on the individual basis. And then next week, we get a bias that's called expert opinion, that I'm the expert at this, so I'm going to decide for you what's wrong with you without you, right? And then mistakes get made. So cognitive bias, implicit bias, in some cases, explicit bias, anchoring bias. There's a whole set of these things that, quite frankly, we fall short in medical education, back to Colonel Coffey's point. And when we look at the malpractice claims, it jumps off the page at us that a bias was involved, that this person wasn't thought through the way they should have been, that what that person or family is saying wasn't heard. One recent example is a young person who comes into the ED with dizziness, quote unquote. He wasn't heard. A 24-year-old shouldn't have a stroke, so it can't be that. So we're not even going to evaluate him for that. Luckily, a nurse then said, why don't we call the family and ask them more about him? And when they did that, they found out that the person that they were talking to wasn't the person that the family knew. So the nurse said, something's wrong. And luckily, they were listened to, and this person had been seen by multiple clinicians. They went ahead and did the proper workup, and he had an AV malformation and could have had a massive stroke that was averted simply because someone was proactive enough in that setting, had the psychological safety in that setting to say, no, we're not going to send him out. There's something else happening here because this is not the person the family knows, right? So thinking through that holistically when a person comes in, backing back from my own biases to make the right diagnosis or at least begin the proper diagnostic evaluation is essential. Back to something that Dr. Coffey said, we're to the point now that we need to put in place fail-safes, redundancies, and forcing functions like standardized order sets and other mechanisms so that people can't opt out of when they're making a clinical decision. Building them into decision support mechanisms becomes important. The one thing that, that decision support, artificial intelligence, medical algorithms, which is a whole nother topic for another day, cannot overcome when medical decisions are made and people's lives are on the line. That is, will you make the right moral and ethical decision? AI can't do that. AI doesn't have a moral soul, but we as human beings do. So when we bring in and all that data, all that information, and it's a lot to Harry's point that you have to process. But for me, that means that there are souls on board in the work that we do. It's not widgets, right? These are people, human beings. And where else should we apply all of the knowledge that we've gained than in the service of people who deserve it?
Thank you. And what I'll be a little bit provocative here because a comment and a question, GPs do not take but do not have sufficient time to listen to patients. In medical school, there's insufficient training in social and interpersonal skills, how to listen to verbal and nonverbal. Should there be empathic training in medical school? In other words, should there be is it time for a revision in the medical training to consider the factors of what we heard from our patients and what you have both said? Dr. Hoare?
Yes, the answer is yes. The answer is also that there are many places, many schools, I would say most medical schools are doing some form of that now. I certainly know that the medical school that we are affiliated with is definitely doing that training. And I'll tell you, the new trainees and physicians who are coming into this, they're going to change things, and I'm very, very positive about, they come in sort of understanding things that I never understood when I was in their shoes, when I was a medical student. They're much more socially aware. They're much more aware of the social determinants of health and the humanistic and compassion, the importance of all of that. I think where we run into a problem is, yes, they learn that. When do they learn that? Usually in the first couple of years of medical school, and then they get into the clinical setting. And always, the do as I say, not as I do, doesn't work. They get into the clinical setting and they see people not doing that. And they say, okay, we're cranking through these patients. We got to move on to the next, got to maximize my billing. And that is the culture that they're inculcated into. And they want to fit into that culture. And so that is the culture that needs to change. So exactly what Colonel Coffey said earlier is, but it's education, but you can't just educate the young, because once they're role models, are showing them how to do things differently, that it's not going to work. And we really need to change what the more experienced clinicians are doing. And that is all about culture, culture change. And I would also want to say a little bit about what Dr. Wyatt was talking about with regards to that case. He mentioned the nurse said, hey, wait a second, got a hold of the family. I think part of the future of diagnosis really is, it is not a doctor and a patient dyad. There should be a diagnostic team, and those team members should have different skills, and that team should be completely non-hierarchical, so that the social worker, the physical therapist, the nurse, the patient, the patient's family are all part of that team, and all have enough psychological safety to be able to say, hey, what about this? Or did you think about this? Much like the airline industry has done over time to sort of remove the hierarchy in the cockpit and has made airline so much safer, incredibly safe. I think we need to move in that direction. One of the things as a tool that we are trying here is a communication tool called AIDIT, which is an acronym for just really teaching people, how do I approach this? How do I make sure I'm really listening and making a patient feel comfortable? AIDIT is really, you walk into a room, you acknowledge, you wait to be allowed in the room. You don't just slam the door open and walk in. Knock. It's the doctor. Is it okay if I come in now? You acknowledge, and then you say, hi, how are you? And what do you like to be called? All of that. And I won't spend a lot of time on the mnemonic, but you can look it up. AIDIT is AIDET. It's acknowledge, introduce yourself and your role, give an expectation of a reasonable time frame, so duration of either the visit or the time that they're going to be in the hospital, or the time that you think it's going to take for that lab result to come back, all of that, explanation of what's going on today, and then a thank you to the patient with an invitation to ask any questions.
Thank you very much. I want to pitch back to our patients. Aubrey, listening to what you heard today and reflecting on your experience, what would be your key takeaway in the next encounter, or what might you say to a patient that might be in the position you were in with your dad?
Yeah, thank you for the question. I would say always trust your gut feeling. And like many of the physicians who have pointed out today on the call, you can never provide too much information. So if there is something that you've experienced, like, you know, the fact that my dad was lethargic, I wish I would have emphasized more on that and whatnot. So I would say always trust your gut and share every bit of information, even if you feel like it's too much information, because as a team, they're the experts that are able to well-rounded and come to a solution.
And Colonel Coffey?
You know, I think we have to look at healthcare, not just medical care. And what I would kind of tell you is that healthcare looks at is an ecosystem. It is not an isolated thing. So medical care looks at the issue that you have, but healthcare looks at the causes of the issue, those other factors. You know, food insecurity looks at all of those other biases that may have that may play in. Medical care looks at the factors, but healthcare as an ecosystem looks at everything beyond just the differential. And so I think that we have to change that perspective of medicine and medical care to look at healthcare, so that we can take into our own personal biases. We can take into all of the other things that factor into diagnosis. So I would say that is the biggest takeaway for me, is to now see healthcare as an ecosystem and not an isolated thing.
Thank you very much. You know, we could go on with this, and I want to say to those that are listening, your questions will be provided to the panelists so that they can respond, and the answers will be made available along with the recording on our website. But I think that we have all learned some practical tips and references that we can use in our doctor-patient interaction. Communication has been very pervasive. Of course, reviewing your chart and taking a responsibility to have that change and challenge where appropriate. I think as at SIDM, we seek out both patients and others in the healthcare delivery ecosystem, as Colonel Coffey said, to help us in joining us in a commitment to safety for patients, so that we can have a zero goal of harm when patients seek care. So I would not be appropriate if I did not leave with a call to action, which is to invite you in the viewing audience. Visit SIDM's website and tell us your story. Medical students, check out the opportunity to help create solutions and offer pathways to expand knowledge across the entire provider community. Follow us on Facebook, Twitter, and LinkedIn. and stay informed through our Improved DX newsletter on the latest news, research, and opportunities to work to improve diagnosis in medicine and patient safety. And of course, support us so that we can continue to host events like this and others, and as well as our annual conference. Finally, I want to thank the staff. I want to thank all of you for bringing this together. I want to thank the panelists for your contributions today. And on the behalf of our board and our partners, I want to say thank you. It has been informative, it has been robust, and I hope you enjoy the remainder of the day. Thank you. The session is now over. Thank you.